So today, I want to talk, like the screen shows, about staffing levels. Now, staffing levels, this is something that came up this week. I was actually working in my retail store, and I had somebody come in that was asking about the class and about certification and where he could work, and places that he could work that offered kind of flexibility in scheduling and that type of thing. But he really kind of got stuck on staffing levels, and I had to take quite some time to talk about this because it's kind of a complex subject. And I thought, if this person is having a hard time with this, I bet other people out there are really struggling with this too. So I figured this would be a good topic for today. So one of the questions that, everybody has is, how many patients can a CNA safely care for? And there is no easy answer to that because it depends on two very specific, well, actually it depends on three, but two very, very specific things that are out of anyone else's control. And that is, how stable is the patient? How much care do they need? And what is the experience level of the person providing that care? So these are two very specific variables that can't be controlled externally. So how much care does the patient need, and how much experience does the person that's providing the care have, right? So the third thing that plays into this is, what setting are we in? Okay, because that's going to have an impact on this too. But the two variables that I really want to talk about is, how sick is a patient, how much care do they need? That's called acuity, ACUITY. You can see it there on the side. Acuity is how much care does that patient need, and how stable are they? How likely is it that that care is going to change during this shift? So how stable are they? So this is called acuity. Now, acuity is going to be different for every single patient. It's also going to be different in every single setting. So that's why staffing is so hard to kind of pin down. So let's say that you're a CNA and I tell you that you have 10 patients today. Now, you might be thinking to yourself, wow, 10 patients, that's a lot. But if I tell you all you really have to do is pass water, answer call lights, help a couple of them to the bathroom, and take vital signs. Well, 10 doesn't sound so bad then, right? Because I can pass water, I can help them to the bathroom, I can take vital signs. 10 doesn't sound quite so bad. Now, I tell somebody else that works in the same place, same hallway, you have 10 patients. Now that person's probably thinking, okay, good, I can handle 10 patients, right? I know that, I got to pass water, take them to the bathroom, take vital signs. And I say, but wait, your 10 patients need total care. You're going to have to turn them every 2 hours, reposition them every 2 hours. They're total feeds. You're going to have to, they're incontinent, so you have to change and clean them. You've got to answer call lights, you've got to pass water, you've got to take vital signs, and 2 of them are not very stable at all, so they require 15-minute checks. Now, you each have 10 patients, right? So from a numbers perspective, this is fine. Both CNAs have 10 patients. But is that really a fair assignment to give one CNA 10 patients that all you have to do is help them to the bathroom, get their water and take their vital signs and answer call lights? And then the other CNA that has 10 patients, they're all total care and 2 are unstable. Is that fair? Does that seem like a fair distribution of care? Probably not. Probably not. If you're the first CNA, you're probably kicking your heels. Yay, I got an easy day, right? And the second CNA is like, hold up, wait. Why does she get off so easy and I've got all this hard work? So acuity is really going to count here. Now, we also have to think about the type of care that we're providing. So this gets really mixed up in CNA world, okay? And I've talked about this before. If you've been on with me for any amount of time, you've heard this, okay? But personal care is not the same as nursing care. Personal care is anything you do for yourself. Bathing, dressing, grooming, eating, toileting, Mobility, that's not really nursing care, that's personal care. It's stuff you do for yourself every day, right? It doesn't really, it's different. It's classified different. Nursing care is specialized tasks that require additional training, right? You don't need additional training to brush teeth. You know how to brush teeth. You had to learn how to do it on somebody else with infection control and safety and all those things in mind. But brushing teeth at the end of the day is still brushing teeth. It's personal care. You're helping somebody do something they would normally do for themselves if they could, but now they can't, so we're going to step in and help. That's personal care. Personal care is different than nursing care. Now, why does this get all screwed up in our heads? Because most people that require nursing care, right? They're sick enough to need a nurse. Most people that require nursing care can't do some of their ADLs, right? They're either too sick, too weak, too incapacitated, too something to take care of themselves. Let's face it, guys, if you could take care of yourselves, where would you be? You'd be home. You wouldn't need anybody. So because they have these nursing needs, right, we're also going to have to take care of these personal care needs because they're here and they can't do it themselves. So this is why personal care gets all tangled up in nursing care. Like, it's really, really hard to separate the two because we kind of figure any care that's done in a nursing setting is nursing care, but that's not technically true. Remember, personal care, things the patient could do for themselves any day, but they can't, so we're going to step in and help. Nursing care requires additional training, higher level tasks. So things like assessment, medications, treatments, care of tubes and catheters and anything invasive, that type of thing. So remember, these are not the same thing, right? So in some settings, you're going to be doing a whole lot of personal care. Think assisted living facilities, right? So assisted living facilities, these are places that people go to. They actually move in. So think of it like apartment living with food, laundry, and housekeeping. That's what assisted living is, okay? It's like apartment living with food, laundry, and housekeeping. So you really don't have to do a whole lot, right? Everything is kind of taken care of for you. So you're not trying to cook and clean and all of those things. So assisted living meets the needs of a lot of our elderly population that just doesn't have the energy to keep up with all of those things. Now, those same people, because they don't have the energy, may need some help with brushing teeth or bathing or grooming or dressing. And that's all personal care. So that kind of falls under assisted living. It's not nursing care. Now, it's important that we understand that. Personal care is personal care. It doesn't matter how much of it the patient needs. It's still personal care. You can have a bedbound patient who's completely stable but needs help with everything, right? Everything is still personal care. So personal care is not nursing care. So acuity is going to take into account, so we're back to that word again, acuity is going to take into account how much personal care that patient needs and how stable they are. They're also going to look at things like how much nursing care do they need. Now, acuity can change rapidly. So you can have somebody who needs very little help at the beginning of the shift, and throughout the shift, they degrade, and now at the end of the shift, they need all kinds of help because things changed over the shift. So acuity can change. Now, it depends on where you are as to how fast that can change. Home care, acuity really shouldn't change that much. In assisted living facilities, it really shouldn't change that much. In hospitals, acuity can change rapidly. So we have to keep that in mind. So in a hospital, you're going to have fewer patients to take care of because those patients can change very rapidly. In assisted living, you may have more patients to take care of because they're more stable, and what we're doing with those patients is more personal care. Does that make sense? Now, the other part of this, is that the experience level, hold on one second, the experience level of the person providing the care has to be taken into consideration. So if you are a CNA with 10 years experience and you've got this stuff down cold, you can probably take on more patients than somebody brand new, straight out of CNA school that really hasn't worked out prioritization and organization, and they're still a little unsure of their skill levels. Those people probably aren't going to be able to take care of as many patients. So when we're talking staffing levels, a lot of CNAs want a law that says CNAs can only take care of 10 patients, period. That's it. And it's really, really hard to write that law because at the end of the day, that law really isn't fair. Because you're going to have some CNAs that are way overburdened and given way more than they can actually handle on the higher end of the care scale. And then you're going to have some CNAs that get 10 patients and they're playing cards in the break room because there's not much to do. So that's not really a fair distribution, okay, of patients. So when we're talking staffing levels, it's not something that a state legislator can just say, okay, CNAs can handle 12 patients, nurses can handle 8 patients. It doesn't work that well. Now, there are minimum safe staffing levels, yes. Okay, so that has said, the state legislature has said for every 30 patients, there should be 3 CNAs, in the facility to care for those patients. But that doesn't assign exactly how many patients that CNA can take care of. Those are just setting minimum staffing levels for the facility based on the number of patients. So when you're getting your assignment, it's important to understand that the person that's creating this assignment, which is the RN, has to take all of this into account, every single bit of it. They have to think about the type of care each patient needs, how stable those patients are, the staff members that they have to work with, and the experience level of those staff members to be able to distribute the workload evenly and make sure the patients get all the care that they need. So staffing is way, way, way more complex than just a number. And remember that these numbers can change throughout the shift. So it's really super, super important that we keep in contact with our nurses when things change so that the nurse can make those adjustments as necessary. But it's also why in the scope of practice of a CNA, you are not allowed to delegate your tasks to another CNA. So the nurse tells you what needs to be done and you either do it or tell the nurse why you can't. You can't distribute those tasks to somebody else because you aren't aware of all of the acuity and experience of the staff. And that's why all delegation has to come from the nurse, taking those two things into account. I hope that helps you guys understand a little bit more about why staffing is really a very, very complex subject. Now, one thing that comes up a lot when we're talking about staffing is, well, wait a minute, wait. If I'm taking care of these patients and I don't feel that I can safely care for them, do I have the right to refuse? And the answer is yes. If you feel that if you have concerns that you're not able to meet the needs of the patient, you need to speak up. You need to tell the nurse, hey, I don't think I can do all that. And let them work with you to either accomplish it or to redistribute the skills. You have to speak up, but you're not going to flat out refuse because those patients still need care. And the nurse has a lot of other things that they're taking into consideration here. So it's not that you are going to flat out refuse because at the end of the day, you don't have the liability that you think you do. All liability actually falls on the nurse. So it's in their best interest because they're still liable. So if you completely ignore one of those patients, you just don't get to them. They haven't been fed, changed, turned, bathed, nothing for a whole shift. That nurse is actually legally responsible for that care deficit. That nurse is. Even though she assigned those skills to you, that nurse is still legally responsible. So the liability always lies with a licensed individual, which in this case is the nurse. Certified, not the same as licensed, okay? Licensed individuals have liability. So kind of keep that in mind. So it's always best to work with the nurses. If you find yourself in a situation where it's you versus the nurses and you're always butting heads and there's a lot of friction there, that is not a good working environment at all, because the patient is always, always, always the one that's going to suffer in that scenario. Always.